Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the next generation Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System with the cordless freedom you expect and the advancements you've asked for. The cordless design reduces the challenge of managing cords in the sterile field and allows for more natural movement in the OR, along with easier instrument exchanges, contributing to a safer OR. Available in 4 shaft links to help meet your specific need, the Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System enables effective vessel coagulation and dissection in open and minimally invasive surgical procedures. And now the Sonicision 7 Curved Jaw system is indicated to coagulate and dissect vasculature up to and including 7 mm in diameter using minimum mode and up to and including 5 mm in maximum mode. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision 7 Curved Jaw system has an improved reusable generator that is now autoclavable and works for 150 procedures before you need to replace it. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse and provides an 88% increase in battery capacity. The Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System. Feel the freedom. Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the next generation Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System with the cordless freedom you expect and the advancements you've asked for. The cordless design reduces the challenge of managing cords in the sterile field and allows for more natural movement in the OR, along with easier instrument exchanges, contributing to a safer OR. Available in 4 shaft links to help meet your specific need, the Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System enables effective vessel coagulation and dissection in open and minimally invasive surgical procedures. And now the Sonicision 7 Curved Jaw system is indicated to coagulate and dissect vasculature up to and including 7 mm in diameter using minimum mode and up to and including 5 mm in maximum mode. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision 7 Curved Jaw system has an improved reusable generator that is now autoclavable and works for 150 procedures before you need to replace it. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse and provides an 88% increase in battery capacity. The Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System. Feel the freedom. Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the next generation Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System with the cordless freedom you expect and the advancements you've asked for. The cordless design reduces the challenge of managing cords in the sterile field and allows for more natural movement in the OR, along with easier instrument exchanges, contributing to a safer OR. Available in 4 shaft links to help meet your specific need, the Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System enables effective vessel coagulation and dissection in open and minimally invasive surgical procedures. And now the Sonicision 7 Curved Jaw system is indicated to coagulate and dissect vasculature up to and including 7 millimeters in diameter using minimum mode and up to and including 5 millimeters in maximum mode. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision 7 Curved Jaw system has an improved reusable generator that is now autoclavable and works for 150 procedures before you need to replace it. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse and provides an 88% increase in battery capacity. The Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System. Feel the freedom. Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the next generation Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System with the cordless freedom you expect and the advancements you've asked for. The cordless design reduces the challenge of managing cords in the sterile field and allows for more natural movement in the OR, along with easier instrument exchanges, contributing to a safer OR. Available in 4 shaft links to help meet your specific need, the Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System enables effective vessel coagulation and dissection in open and minimally invasive surgical procedures. And now the Sonicision 7 Curved Jaw system is indicated to coagulate and dissect vasculature up to and including 7 millimeters in diameter using minimum mode and up to and including 5 millimeters in maximum mode. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision 7 Curved Jaw system has an improved reusable generator that is now autoclavable and works for 150 procedures before you need to replace it. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse and provides an 88% increase in battery capacity. The Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System. Feel the freedom. Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the next generation Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System with the cordless freedom you expect and the advancements you've asked for. The cordless design reduces the challenge of managing cords in the sterile field and allows for more natural movement in the OR, along with easier instrument exchanges, contributing to a safer OR. Available in 4 shaft links to help meet your specific need, the Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System enables effective vessel coagulation and dissection in open and minimally invasive surgical procedures. And now the Sonicision 7 Curved Jaw system is indicated to coagulate and dissect vasculature up to and including 7 millimeters in diameter using minimum mode and up to and including 5 millimeters in maximum mode. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision 7 Curved Jaw system has an improved reusable generator that is now autoclavable and works for 150 procedures before you need to replace it. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse and provides an 88% increase in battery capacity. The Sonicision 7 Curved Jaw Cordless Ultrasonic Dissection System. Feel the freedom.
Good evening, everyone. Welcome to this evening's webinar. I would like to start and welcome each and everyone that's once again part of the Sonos webinars that we have actually been doing now for the past almost 4 years. The same tonight. The whole idea of this webinar series that is part of topics being discussed appropriate to the field of head and neck. Try to keep it as practical and also academical as possible, also always having international guests being part of this, and tonight is nothing different. For those that don't know me, my name is Johan Kluge. Nice to meet you. I'm a head and neck surgeon working at Syntocare, chairing Sonos at the moment. Also on the EXCO of the International Federation. And I would like to welcome my co-host tonight, Professor Chris Joseph, also a head and neck surgeon, past president of Sonos, past president of South African Head and Neck Society. Good evening, Professor Joseph. Welcome to this meeting tonight, and thank you for being a part of this.
Yep, thanks very much for asking me, Johan. So looking forward to a good meeting. Good.
Thank you very much. Thank you so much. I would like to start the meeting tonight, and of most of all that in the ENT fraternity knows, I would like to dedicate this webinar tonight to a colleague, Dr. Mark Torres Holmes. He was part of IFNOS's EXCO as well, Sonos's EXCO. He was always my co-host from the beginning that we started with this webinar series. Mark was always the co-host, and I would like to dedicate this webinar tonight to him. I'm going to dearly miss him. And Mark, we miss you. You were a great guy and a great colleague and a great surgeon. To continue, before we start with the meeting tonight, I quickly want to showcase just a short video. So for the first time this year, we decided to do a local, actually national head and neck cancer screening and awareness. And this was the first time we ever embarked on such a journey. Sonos tried to actually make head and neck cancer more aware, raise more awareness in South Africa. And this year we actually managed to involve capital cities. We had Johannesburg, Pretoria, Durban, and Stellenbosch being part of this. In specific, I want to thank Medtronic, specifically Ms. Luhan van Vieren. I also want to thank Storts, specifically New Medical as well. So a short video just to showcase exactly what we did in the past 5 weeks. So sit back and please enjoy this. Thank you. And I think it's time now to start the webinar. Good evening, everyone. Once again, for those of you that just joined, I would like to start to quickly just introduce the speakers and panel members for tonight. To start quickly with our international guest. Good evening, Professor Piazza. It's an honor to have you here tonight. Professor Piazza is a head and neck surgeon. He's got a long CV. But in short, or part on the EXCO of the International Federation of Head and Neck Oncological Society. He's also the past president of the European Laryngological Society. And like I said, the list goes on. Prof. Piazza, welcome to this evening's webinar. It's, like I said, an honor to have you here. We're looking forward to your comments and insights on the topic being discussed tonight. Then, of course, Professor Sonia Boy, she will be the first speaker for this evening, talking on the genetics of paragangliomas. Prof. Boy is a head and neck and oral pathologist, very experienced in her field. So we're really looking forward to specific topic, very appropriate as well tonight to the webinar. Then Dr. Louis from Papendorf, he's a head and neck radiologist. And then Dr. Philip Eloff, vascular surgeon at Syntocare. He will also have, I think, a very appropriate discussion tonight, specifically on the surgical management of carotid body tumors, and then tips and pulls. Also some live pre-recorded surgery, so looking forward to that. And then, yeah, of course, then the rest of our panelists that will join as part of the discussion. Dr. Dirk Leroux, past president of VASA, vascular surgeon working at Netcare Sunninghill Hospital, as well as Dr. Ngema. Dr. Ngema is currently the HOD at Sefako Magatu. So, yeah, good evening, everyone. Good evening, gents and ladies. Thanks for tonight. Looking forward to it. So, without no further ado, I would like to introduce Professor Sonia Boy. Prof. Boy, welcome to this evening, and we look forward to your lecture.
Good evening, Dr. Kluge. Thank you very much for inviting me to give this lecture on the genetics of paraganglioma. Unfortunately, this is a massive subject, and a 15-minute overview definitely not a way to get through all of this. So I've decided more aptly to call the lecture "The Genetics of Paraganglioma as Applicable to the South African Head and Neck Surgeon." We unfortunately do not have access to all the genetic evaluations as seen in other countries, and that is a bit of a problem. So for this lecture, I want to talk a little bit about the terminology changes, which is applicable to all of us, the concept of malignant paraganglioma and how that has changed from a pathological and surgical point of view, and then a little bit about the genetics that's applicable to us all and how all of this basically holds hands. So the 5th edition of the WHO classification of tumors of the endocrine and neuroendocrine system divides the paraganglioma into sympathetic and parasympathetic. The parasympathetic paraganglioma specifically referring to the head and neck paraganglioma. Now, the reason for this is because the parasympathetic chains are mostly situated in the head and neck. Now, the WHO feels quite strongly that we need to move away from site-specific terminology, such as glomus tumors, carotid body tumors, etc., and stick to the terminology of parasympathetic paraganglioma or head and neck paraganglioma in this specific case. The ICD-10 codings are all /3, as you can see, and this was decided in 2017. Before that, we classified these neoplasms as of uncertain biological nature, but in 2017, it was decided to go for malignant classification for all of these neoplasms, specifically because of their unpredictable nature. The updated 2023 classification of the head and neck tumors specifically. Chapter 15 is the neuroendocrine neoplasms and paragangliomas, and even here you can see that the paraganglion tumors are called head and neck paragangliomas specifically, and the WHO then again prefer for us to move away from the site-specific terminology and rather use head and neck paraganglioma or then parasympathetic paraganglioma, or also acceptable is only paraganglioma when STH is intact, or STH deficient paragangliomas, and I will get to that just now. So these are well differentiated new non-epithelial neoplasms of the autonomic and specifically the parasympathetic system in the head and neck. Unlike those found in the abdominal cavity, such as the adrenal gland tumors, the head and neck tumors are usually non-functional or silent, and very few, in fact less than 4% of head and neck paragangliomas will have secretory function. It is advised that a patient diagnosed with a head and neck paraganglioma be tested for secretory function, and if you do find any form of elevated epinephrine levels or any other product, to actively exclude the presence of concurrent sympathetic chain paragangliomas or few chromocytomas before accepting it that this is a sporadic head and neck tumor with active secretion. Then there's the concept of malignant paragangliomas. When I was a registrar and also up to very recently, when we find paraganglioma tumor deposits in a lymph node, for instance, or anywhere else, we would then use the term malignant paraganglioma, and that was the only criterion that we had. But it is now accepted worldwide that there are no cytological, histological, immunohistochemical, or molecular criteria that can help us classify paragangliomas as malignant neoplasms. We do have a set of adverse prognostic factors that's been published all over. The first being a so-called incomplete resection, but for me as histopathologist, this is very difficult. I've never seen a complete resection, so to speak, because we usually receive the tissue piecemeal, which is of course understandable due to the difficult anatomic location and removal in the head and neck. The next thing is a high mitotic rate. This can be determined by looking for mitotic figures, but also doing a Ki-67 immunohistochemical stain, which is advised nowadays and should be done standardly. Then the concept of necrosis and diffuse growth pattern. One can look at this image here. This is an area of necrosis, and if you compare that diffuse growth pattern to this more Zell-Bullen, the classical growth pattern of paragangliomas. I prefer to do a S100 or SOX10 stain to highlight the cystentacular or the supporting cells which are situated at the edge of these so-called Zell-Bullen. And of course, in a such scenarios such as this, you have diffuse growth, you have loss of your normal cystentacular cells, and that appears to have or be an adverse prognosticator for future management of these patients. So for now, all paragangliomas are considered to have metastatic potential, and even those in the head and neck, up to 15% of them will metastasize. Now, for now then, we prefer the term metastatic paraganglioma to malignant paraganglioma when we find paraganglion tissue in sites where you do not expect it to be. And we prefer the term non-metastatic paraganglioma to benign paraganglioma, as the WHO do not really expect or accept the term benign with regard to these tumors, considering the ICD-10 code changes as well. These are the most heritable human neoplasms known to us, and more than 80% of these tumors will be explained by some sort of genetic alteration. More than 40% will be attributed to germline mutations, and in these patients there is a high probability of multifocal disease. Unfortunately, this gives us a little bit of trouble because in a patient with a germline predisposition syndrome, such as is the case with the paraganglioma syndromes, these patients can present with multiple lesions and multifocal lesions. And in that case, it's difficult to call it a metastatic tumor rather than just a multifocal tumor. So that makes it quite difficult to know. And also they can present with paragangliomas in unusual locations. So one has to be a little bit more cautious with the terminology in these patients, and that is why the genetic testing is so important. The field of genomics with regard to these tumors has expanded immensely over the last few years, and the Cancer Genome Atlas group has published numerous germline, somatic, and fusion gene mutations to be related to the development of paragangliomas. So for now, all patients diagnosed with paraganglioma for the first time is advised to have some form of genetic testing to exclude the possibility of a hereditary syndrome background for the development of this neoplasm. Even patients with a seemingly sporadic tumor in the head and neck, such as, for instance, one carotid body tumor, will have a background of a hereditary syndrome in up to 35% of cases. So it is important to exclude this possibility from the start. When it comes to the head and neck paragangliomas, a lot of these patients will have a germline mutation in one of the 4 subunits of the succinate dehydrogenase complex. This is a mitochondrial electron transport system situated in mitochondrial membranes, and it has all these subunits A, B, C, and D, as well as cofactors, and these are all collectively referred to as SDHX. So a lot of these patients will have some form of germline mutation in one of these subunits. The most common germline mutation of SDH in patients with head and neck paragangliomas is the SDHD unit, followed by SDHB and then SDHC, and much fewer SDHA mutation being published. Now, the reason why it's important to know where the mutation is situated is because there's clinical differences between the patients with the different subunit mutational factors. Now, for instance, a patient with an SDHB mutation tend to have much more aggressive disease. They tend to have a higher rate of metastatic disease compared to a patient with an SDHD mutation, which usually only will have a head and neck paraganglioma and much less incidence of pheochromocytomas. Now, molecular immunohistochemistry for SDHB testing has been developed and is a very good screening tool that can help us predict pathogenesis of the tumors present. It has been shown that if you have loss or mutation of any of the subunits of this complex, SDHB will be degraded, and immunohistochemically there will be loss of SDHB, which can help us to see if there's a possibility of a germline mutation. So SDHB immunohistochemistry is quite a reliable surrogate marker for syndromic loss of SDH. Now, currently, the WHO basically recommends that all paragangliomas of any anatomic location be tested for loss of SDHB, and this is an example. For instance, this is a positive SDHB normal cytoplasmic granular staining of all the cells present. That is an example of a negative SDHB stain, which means there's loss of normal SDHB. So SDHB has been degraded either as a result of mutation in SDHB itself or in any of the other subunits. This blush type positivity, some has published that if you have, for instance, mutation in the SDHA subunit, you can have a blush cytoplasmic positivity such as that, and that there might still be a background of genetic pathology, so this should be taken further for evaluation. This is important because lots of studies have shown that when a patient is made known of their genetic background, in the case of these neoplasms, they will go more easily into surveillance programs, and compared to patients who didn't know about their genetic status, they do better at follow-up. They do not get lost to follow-up, and when they do follow-up and there are new tumors, because these patients have a higher possibility of multicentric disease, they can be managed earlier, and Overall, the 5-year survival rate of these patients with knowledge of the genetic status is so much better than those with no knowledge. So the take-home message from my side is the terminological changes. Then the concept of malignant paraganglioma, that we should rather use the term metastatic, but to take cognizance of the fact that patients with germline predisposition syndromes can have multicentric disease, which does not mean metastatic, and that's why we prefer to manage all patients with paraganglioma as malignant disease rather than anything else. And then very importantly, that genetic testing and screening is mandatory. In South Africa, we do have SDHB immunohistochemistry to triage these patients. So in summary, if you have a patient with a new diagnosis of paraganglioma, please ask your pathologist to do an SDHB immunohistochemistry for triage. If there's loss of SDHB secretion in that specific neoplasm, then the patient should be sent for genetic screening and counseling. And in certain cases, the geneticist will then also counsel the entire family for follow-up and screening to exclude pathology in close family members. And these families with proven genetic mutations or germline mutations can then actually go into an active surveillance program for the rest of their lives. These people have the need of lifelong follow-up for the development of new tumors. Thank you very much. I hope this has given you some sort of insight into the new changes and also the fact that we can do a triage, but then the patient should be submitted for genetic work, which one can use a geneticist for, and they will send blood. In our case, we send it to Germany. They do the genetic analysis and get a positive feedback whether the patient do have a germline mutation or not. Thank you very much.
Thank you, Professor Boy. I think that's a really, really good summary in a very short period of time, and well done. Thank you for that brilliant presentation. My suggestion is that we leave the questions for later. We do have a session Q&As. Maybe just quickly, Piazza, comments from your side before we hand over to Dr. Louis van Popendorf to speak about imaging and carotid body tumors. Prof, do you want to make a short comment, or can we leave it to at the end of the meeting?
Yeah, I appreciated a lot the wonderful presentation of our colleague because it's focused on very easy concept and the very basic ones. The first one, that there is no definition of malignant and benign disease in this field without a long history. Because for definition, you define a malignant lesion only in this field when you find a metastatic deposit on the lymph nodes or a distant metastasis, but this can happen even 5 or 10 years after the first surgical resection. So it's an important clue that we have to keep in mind. The malignant or benign nature of this disease is not defined at the diagnosis or at surgery, but it must be kept in mind and especially stratified according to the SDHB evaluation that was very precisely outlined in this presentation, and it's the cornerstone of our suspect of malignant or metastatic or non-metastatic nature of our disease. Thanks for this wonderful presentation.
Thank you, Professor. Highly appreciate it for that comment. Prof. Boy, if you want to quickly comment, otherwise we continue.
Not for now. Thank you, Johan.
Thank you, Professor. So, Dr. van Popendorf, good evening. Thank you so much for being here this evening, and we're looking forward to your presentation. Thank you so much.
Yes, thank you very much for the introduction, Dr. Kluger. Good evening, everyone. So I will be speaking about the imaging findings in carotid body tumors. So let's delve right into that. We'll start with a quick introduction. We know that these paraganglioma are highly vascular structures. So this is a very important term that will also come up later in the presentation because it is a cause for a lot of the characteristic imaging features of these lesions. They arise from the chemoreceptor cells of the carotid body. In other words, where do we find them? We find them at the carotid body, at the bifurcation of the common carotid artery. And the majority are benign or non-metastatic, as we've just heard. So you'll be looking out for benign type features in a lesion. Some of them can, however, undergo more malignant change. Having a look at the epidemiology, in which patient population would you expect to find these paragangliomas? You need to keep that in mind. So first of all, they are more common in female patients, generally diagnosed in the 4th to 5th decades of life. So middle-aged female patients have a high clinical index of suspicion. The carotid body tumors are the most common type of head and neck paraganglioma, but they overall account for very little of overall head and neck tumors in general. Getting over to the location, so where do you look for them? Basically at the carotid bifurcation, found within the carotid sheath, so radiologically will be defined as within the carotid space, and with this very characteristic splaying of the internal and external carotid arteries. Now this sentence will probably come up 10 more times during the presentation, because this is the single most important characteristic, is the splaying of the internal and external carotid arteries. And then, of course, you get the familial, the genetic cases, as we've just heard, and they will more commonly be bilateral or multicentric on the one side. So we'll look into that also a little bit later. So just to have a look at the different head and neck paraganglioma, or glomus tumors, as they were previously called, as characterized by their location. So most common would be the carotid body tumors located in a region of the carotid body, followed by glomus tympanicum in the middle ear cavity, glomus jugulare, and glomus vagale along the course of the vagus nerve. In terms of your clinical presentation, so I'm a radiologist, so I had to go read these up on the internet. But basically, they say you get an asymptomatic anterior neck mass. That's the most common presentation, just a lump in the anterior neck. This lesion can be moved from side to side, but not up and down. And this makes sense if you think about it, because it sits within this V-shaped configuration of the common carotid artery. So you'll be able to move it up and down, but will be limited you'll be able to move it side to side, but will be limited in the up and down direction by the common carotid artery itself. Symptoms mainly would include a local pressure effect caused on the structures within the carotid space. So structures that can be compressed would include the internal and external carotid arteries, the internal jugular vein, and then of course your cranial nerves that traverse the carotid space. So think about cranial nerves 9, 10, 11, and 12. Patient can present with any of these nerve fallout. And then, of course, some of the lesions can also produce secretions, as we've seen just now. That's very rare for the head and neck paraganglioma to cause actually secretions and catecholamine-related symptoms like palpitations, headaches, and hypertension, etc. So just to look at a clinical presentation, you can see there's a little bit of a fullness anterior to the sternocleidomastoid muscle at the level of the carotid body. Let's get to the imaging modalities. So you can use any type of imaging modality actually to try and image the carotid body tumors. I've outlined the 5 most common ones, starting with ultrasound, CT scan, MRI, digital subtraction angiography, and we'll look a little bit at nuclear imaging at the end. So starting with the First one, imaging characteristics, starting with the first one on ultrasound. Most clinicians will prefer to start with an ultrasound evaluation of an asymptomatic neck mass because it's a non-invasive, easy, and a cost-effective screening type study to characterize a lesion. What will it look like on ultrasound? You're going to find a well-defined mass. We said most of them are benign-like, a hypoechoic lesion, meaning that it will be dark on the ultrasound. And if you put your color Doppler function on, it will be characterized with hypervascularity within the lesion itself. So let's have a look at a few examples. So in the left top corner, you have a sagittal or a longitudinal ultrasound. You can see the common carotid artery with its bifurcation. And in the bifurcation, you get this well-circumscribed hypoechoic mass lesion. This is now on your normal B mode ultrasound image. In the bottom corner, you have the color Doppler, and you can see the flow within the carotid vasculature, but you can also see extensive flow and internal vascularity within the lesion itself. Another example, it looks basically similar as the previous image. Again, your B mode image with this hypoechoic well-circumscribed lesion. And the only difference in this slide, we used power Doppler, which is a more sensitive Doppler function where it sacrifices the direction of blood flow. But you can clearly see that there are numerous small, tiny little blood vessels throughout this lesion, giving it its hypervascular appearance. Just another example with a normal color Doppler with your carotid artery, your external carotid artery, internal carotid artery, and your carotid body tumor sitting in the middle of them. If we move over to a CT scan, the most important thing to remember is you have to give contrast. The best would be if you can do a CT angiogram. And what you'll be seeing on the CT angiogram is a well-defined soft tissue mass with rapid, avid, and homogeneous contrast enhancement. And that's due to this high internal vascularity that we've just mentioned. The characteristic splaying of the ECA and the ICA, as we've mentioned also earlier. And because CT scan has quite a large field of view, you'll probably, if you do a neck angiogram, you'll be scanning from at least from the aortic arch to the base of skull. So you'll be able to demonstrate further extent of disease, any bony involvement, any multicentric disease within the head and neck region. So that's a benefit. If we look at some examples, so these are both CT angiogram images. On the left, sagittal slice, and on the right, an axial slice. So let's look at the left first. So you can follow the common carotid artery all the way up to the bifurcation. It bifurcates into the internal carotid artery and the external carotid artery. And in between these two vessels, you get your mass. It's quite homogeneous, avid enhancement with internal hypervascularity. You know this is the internal carotid artery because it does not have any branches coming from it. So that would be a classic example. On the right-hand side is this very characteristic splaying of the vessels that we've mentioned now a couple of times. So anteriorly, you have the external carotid artery, and posteriorly, you have the internal carotid artery. And in between, there's quite a substantial amount of tumor that is displacing these vessels from each other. But other than that, it's avidly enhancing, it's well circumscribed, benign looking mass. Let's have a look at another example. This is a different patient, and I put this example in because you can also again see the ECA and the ICA, but in this case, both these vessels are encased circumferentially 360 degrees around each of those vessels. So obviously that would make the surgical management a little bit more tricky. As well as you can see the internal jugular vein that has been displaced all the way towards the left and actually quite flattened with mass effect on this vessel as well. So you need to look for secondary complications or mass effect as well. Last CT image, just a nice example of the splaying of the ECA and the ICA on a sagittal plane. Then on CT, there is a very important classification, which we call the Shambling classification. Basically, it refers to the extent of a tumor contact with the carotid artery, with the internal carotid artery. It's graded as, well, basically type 1, type 2, and type 3. Type 1 being less than 100 degrees of a tumor encasement. Type 2 between 180 and 270 degrees of encasement, and type 3 more than 270 degrees of encasement. And basically, this is just an indication of the risk of adventitial involvement of the internal carotid artery. And obviously, you know, as the types increase from type 1 to type 2 to type 3, so does the risk for surgery also increase. So let's have a look at the image for that classification. We have type 1, type 2, and type 3. This is a little bit more complex than I've just explained. But if you have a look at the images at the top, they've also included a few nerves running within this location. So within the carotid space, usually you get the vagus nerve, cranial nerve 10, you get cranial nerve 12, hypoglossal, and the superior laryngeal nerve as well. So these structures are all just abutted in the case of type 1 lesions. Type 2 lesions, they start to get encircled between 180 to 270 degrees, and in type 3 cases, more than 270 degrees, usually with complete encasement, as that example that I've just shown now. Moving on to magnetic resonance. So magnetic resonance imaging is your gold standard because it has superior soft tissue resolution. CT scan is also very, very good these days, and you can get a lot of information from that, but they consider magnetic resonance as the gold standard. It provides an accurate delineation of the tumor's relationship with the carotid bifurcation. And then if you look at your basic sequences on T1, lesions will appear hypointense, that means dark. T2, hyperintense or white. T1 gadolinium, after contrast administration, you're going to have avid contrast enhancement, so also white. And these lesions may actually show a little bit of diffusion restriction also on your DWI sequences. So let's have a look at some of these examples. So this is these are different sequences in the same patient, sagittal plane. On the left, you have a T2 weighted image, and on the right, you have T1 with contrast or gadolinium. And you can see that these lesions look very similar if you compare them. If I were to cut off the image at this level and take out the fluid signal from the ocular globes and the brain, you would actually not be able to accurately distinguish between a T2 and a T1 GAD, right? So you get this on T2, you get this very hyperintense or white lesion with your internal vascularity. And on the T1 GAD, the white lesion is due to contrast enhancement. But on the T1 without GAD, this all would have been dark in color. So this is just another example of a T2 weighted disease or a T2 weighted sequence. Basically, you have your lesion on the right. It's showing this characteristic splaying of the ECA and the ICA with tumor in between. It's hyperintense. And just to also make sure you have a look at the contralateral side, because this is a case of bilateral disease, and there's a smaller tumor on the left with similar characteristics that one might miss if you just tend to focus on the bigger tumor. On MRI, you can also use a specific technique called MR arteriography, basically just to delineate the relationship of the vasculature to the lesions. This is also a case of bilateral disease. On MRI, there's another sign that is important, and they describe it as the salt and pepper sign. And the significance of this sign is it's just basically an indicator of the high internal vascularity of the lesion itself. So basically, on T1, they described foci of microhemorrhages or small hemorrhages that manifest as hyperintensities or little white dots that would look like salt or represent a salt. And on T2, numerous small vascular flow voids that would appear black or dark, and that would represent the pepper. So I've seen people describe this sign just based on a T2 weighted sequence alone, or even a T1 GAD sequence, where it basically describes the black little vascular flow voids on a white background of either hyperintensity with T2 or contrast enhancement with T1. Personally, I haven't come across a very nice example or a classic example of the little foci of hemorrhage or hyperintensities on a T1 weighted imaging sequence, and that is so I've come across many people describing the sign solely on the T2 weighted sequence. So let's have a look at that. Both these are different patients. Both these are T2 weighted sequences. And you can appreciate your mass lesions, first of all, and on the background, you get this white appearance, a little bit of a nodular type of white appearance that represents the salt. And more importantly, on the inside of the lesion, these little black dots and lines that represent the hypervascularity, and that would basically be making up the salt and pepper sign. So this is just another example. It's a little bit of a blurry image, but you can get the idea of these little black dots in the center of the lesion. Moving on to a little bit more invasive imaging, digital subtraction angiography. So on this imaging modality, again, you're going to find the characteristic splaying of the carotid vessels. This time they give it a specific name. They call it the Lyre sign, and note this would be L-Y-R-E, Lyre sign. But you can also apply this actually to the other modalities. It's not specific only to DSA. Another important finding that we'll have a look at in a moment is the intense contrast blush that you can expect to find once the contrast starts washing out on the DSA due to the hypervascular intrinsic features. And just to remember that the main arterial supply to these carotid body tumors, specifically from the external carotid artery, particularly usually from the ascending pharyngeal artery. So I'm going to take you through a sequence or a complete run of the left common carotid artery on digital subtraction angiogram. So you can see it's an angiogram, and you see that all the rest have been subtracted, and that's where the name comes from, digital subtraction angiography, so that you can see the vessels very nicely. The catheter tip is located in the left common carotid artery, and you can see this is the first image obtained of the run. It's purely arterial. And if we move a little bit further, you can see the internal vascularity starting to accumulate in the region of the carotid body tumor. You have, again, this classic splaying of both the ESA and the ICA. And as you move on, the contrast starts to wash out of the arterial phase and move more into the venous phase. And at that stage, you get this very characteristic or classic blush of contrast in the region of the tumor. And because of the tumor, the hypervascularity within the tumor retaining the contrast during this phase. And this is a classic sign. Just to get back to the Lyre sign, so this on the left is a lyre. It's an ancient type of instrument. It's a harp-like type of instrument, kind of resembles a harp. And it has this very characteristic shape that you can see if you look at the image on the right. This splaying of the ECA and the ICA resembles the shape of this lyre instrument. And the internal strings also very aptly will correspond to the internal vascularity within the tumor itself. Almost done, so let's just have a look at the nuclear imaging. So we know that the paragangliomas are neuroendocrine class of tumors, which means that they will show radiotracer uptake with MIBG and octreotide scintigraphy for well-differentiated lesions. At our institution, we do PET CT scans, so specifically the dotatate type of PET CT scan for the evaluation of these lesions. And the biggest indication for the use of dotatate PET imaging is it's useful for the assessment of multiple lesions, right? So if you have multicentric disease or if you suspect multicentric disease in familial or genetic cases, that's when you'll do a dotatate PET scan, as well as if you suspect metastatic disease. Let's say you have a few lymph nodes that you are unsure of. So this is just one image that basically depicts a dotatate PET fused image on the right. So on the left, you have your normal contrast enhancement, bilateral disease, and on the right, you see the radiotracer uptake within these lesions. Then just lastly, to have a look at the differential diagnosis. So the most important differential would be a vagal paraganglioma. So this is basically the same type of tumor. It's just occurring in a different location along the vagus nerve. So where you had the carotid body tumors basically causing splaying of the internal and external carotid arteries, your vagal paraganglioma is located more rostrally, more posteriorly, and it displaces both the ECA and the ICA anteriorly, and commonly the internal jugular vein posteriorly. So let's have a look at an example. So this is your glomus vagalis. So on the left, you have an MRI scan. On the right, you have a CT angiogram. We'll start with the MRI. You can see the vascular flow voids within the ECA and the ICA anterior to the lesion. And on the CT scan, the same thing. You see them anterior to the lesion without a lot of tumor in between the lesions causing this characteristic splaying that we've been emphasizing throughout the lecture. So the lesion is located more posteriorly, displacing these anteriorly. The internal jugular vein not clearly visible on these images, but that would be classic for the vagal type of paraganglioma. The rest of the characteristics are the same. So it's still an avidly enhancing, highly vascular lesion with vascular flow voids, except for this configuration of the ICA and ECA. The second one in your differential, you have to think about a vagal schwannoma, basically going to have the same splaying pattern as the vagal paraganglioma, but it tends to have a little bit more fusiform shape, and obviously without the salt and pepper sign as we've explained earlier. So if you have a look at some of the examples of a vagal schwannoma, these are both MRI scans. Let's have a look at on the right. So you first of all, you see the ECA and the ICA that is displaced anteriorly, and you have the internal jugular vein that's displaced posteriorly. So there's nothing in between. But if you have a look at the lesion itself, okay, it's well circumscribed and it has a benign type appearance, but it's not as if they are. It's with these classic hypervascular flow voids within them. Let's have a look on the one on the left as well. This is a T1 weighted image, and you can see it's much more homogeneous appearing. There's a little bit of vessels inside, but it's not as classically hypervascular as your paraganglioma tumors. So this is a difficult differentiation. Then lastly, just second bronchial cleft cysts also within the differential diagnosis. Obviously, they'll be cystic, and as well as hypervascular lymph nodes, lymphadenopathy, metastatic lesions in and around the carotid space, also to keep in mind within your differential. Let's just have a look at the second bronchial cleft cysts for an example. So these are both CT scans. Now, these lesions you can see are located more laterally to the ECA and the ICA. So it's all about the relationship to the ECA and ICA. And internally, you can see they are cystic. These aren't solidly enhancing lesions, maybe with a bit of rim-like enhancement, but cystic lesions not splaying the ECA and ICA. And this would be a more easier form of differentiation on imaging. Right, so just to conclude, carotid body tumors can actually be very accurately diagnosed using the imaging findings. If you see these classic or characteristic features that I've shared with you just now, you can be quite certain that you are dealing with a carotid body tumor or a paraganglioma. The main features of them including hypervascularity with this intense contrast enhancement that we've mentioned a couple of times, and the characteristic splaying between the internal and external carotid arteries. And then just as a last note, the imaging is crucial for effective treatment planning. Like we've seen in the Chamberlain classification, you need to have a look for the involvement and or encasement of very important arteries in the head and neck region. And that is what we'll be focusing the next portion of the webinar on, is the surgical management. So thank you very much for your time and attention. And that would be all from my side. Thank you very much.
Thank you, Dr. van Papendorf. Once again, I think it's a great summary of imaging and the role of imaging. Thank you for elaborating a little bit more on your differential diagnosis. I think it was very appropriate. Maybe just quickly, 2 questions that I can post, maybe to the other panelists, if it's suitable. Dr. Leroux and Dr. Ngema, what is your choice of modality using in your units that you are using in your units after this discussion, if I may ask?
Good evening, and thank you for having me. So in our institution, we'd always start off with the ultrasound, and if there's clinical features in keeping with your carotid body tumors, then would proceed to offer the patient a CT, contrasted CT scan. It basically has to do with mainly resource constraints and lack of availability, so would not proceed to do an MRI in that setting, but it's essentially ultrasound followed by a CT. Thank you. This is in the state sector. Thanks.
Thank you. Thank you very much, Dr. Leroux.
Yes, Jan, I think I agree. We would also, as previously discussed, just make sure that there's no secretion of any of these tumors and go look any further, So if there's any secretion of your adrenalins or the catecholamines, we would also go and look further in the abdomen along the sympathetic chain just to see if there's nothing else. But other than that, I agree with Sam. Thanks.
Thank you. Thank you. Appreciate it. I mean, I am going to quickly ask Prof. Joseph if he wants to comment. And just before that, I'm going to post a poll just to everyone attending. Maybe just of interest, please interact, and you will see the poll that will be shared up on your screen now quickly, to say what is the most common imaging modality used in your unit: ultrasound, CT with angio, and the MRI. Of course, I mean, there is a combination of it, but I mean, I think what's the most common imaging modality used primarily in your unit, according to your availability. Please be so kind to interact. Prof. Joseph, any comments from your side?
Yeah, thanks, Jan. It's similar. Even in private, we'll just use ultrasound and CT scanning. We don't really go to others unless we're concerned about, multiple tumors. So which is rare, as has been pointed out. So we don't always test for catecholamine secretion either if there's really no symptoms. So yeah, it's all a matter of, although all these modalities are available to us, one is always aware of the costs. So we do go on a clinical presentation, but certainly MRI if we're concerned about the internal carotid. But quite often the ultrasound will give us the information we need on that. So yeah, it's mainly ultrasound and CT scanning is our mainstay.
Yeah, and I agree with you. I think in the hands of a good sonographer, you can get very far. It's relatively cheap. It's non-invasive. Prof. Piazza, if you want to...
if I can add a comment. In case of young patient with a large lesion more than 4 centimeters, Chamberlain 3, with an SDHB mutation, after this you have to check with the gallium PET scan or whatever the presence of multiple disease, because this can be a game changer for this patient. It's rare, it's about 15-20% of patients that this happen, but if this is a metastatic disease or multiple sites disease, this will completely change your approach to the disease, perhaps not locally, but in the follow-up or multiple surgeries you will have to screen this patient appropriately.
Thank you, Professor Piazza. Thank you very much. I don't know if there's any further questions. We have a nice time slot at the end. So I think let's move on. I would like to present our next speaker, Dr. Philip Elof. Dr. Philip Elof is a vascular surgeon, as I mentioned as well. And Dr. Elof, thank you so much for joining us tonight. Thank you for taking on the topic I think that everyone was waiting for, and that's the surgical management. Thank you, Dr. Elof.
Good evening, everybody. Let me just start my talk. I've got two disclosures. The first disclosure is that after Prof. Boy's talk, I changed my heading from carotid body tumors to carotid body paragangliomas. And the second disclosure is that, as you can see on my first picture, is that I'm quite an avid aviation enthusiast. And I'll try to mix these two topics as we go along. Now, with researching the topic for tonight, I came across these two articles in the South African Medical Journal. The first was published by Jacobs in 1954, and the second by Gaylis and Pantanovich from Wits in 1987, over a period of period of 30 years. And just to give you an idea of what they were up against almost 70 years ago, I'm just going to read the first paragraph of this publication from Jacobs, and he said there, carotid body tumors are not frequently encountered. Only 4 more than 300 have been reported in the world medical literature. The operative removal of carotid body tumors may be very perplexing and formidable procedure, even for the most adept and experienced surgeon. Collecting statistics reveal a very high operative mortality, early post-operative death being generally considered to be as high as 30 to 33%. And of those patients who survive, a lot of them will have permanent post-operative disability. When you look at the second article here by Gaylis and Pantanovich group, they published their experience over a period of 22 years with 52 carotid body tumors, and you will notice that the death rate during that period of time decreased to 4.5%, and the morbidity, specifically cranial nerve injuries, that decreased to about 10%. Now, thinking about that, I basically came to the conclusion that like in surgery, like in aviation, things have not changed that much. We still fly our planes and we still do our surgeries, but we've refined the way we fly them. On the left is my Bonanza. It's a F-33 with old steam gauges. It still flies very well. And on the right is my Cessna 210, which has got a glass panel, and it's much easier to fly the one on the right, much less stress and load on the pilot compared to the one on the left. And I think in a similar fashion, the same thing has happened to managing these tumors. Just an overview. I'm not going to spend too much time on all of them, as a lot of this has been addressed by the previous speakers. Basically, some basic sciences, clinical presentation, diagnostics. I'll just say a couple of words. And then the management is what we will focus on more specifically, embolization and surgery. Getting back to the epidemiology, some of this has been mentioned, quite rare tumors. Major centers usually see about 1 case per year. In our unit, we probably see between 4 and 8 per year currently. I think after the passing of Professor van Marle, in my practice specifically, I've started to see a lot more of these tumors. He was the one who was performing most of these procedures in the Pretoria area. And then when comparing male to female ratio, quite interestingly, patients at high altitude, there's quite a strong female preponderance with 8.3 to 1. However, at sea level, that is almost equal 1 to 1. As mentioned before by Professor Boy, that bilateral, you will often find them if the patient has got in 32% of patients, and it's an autosomal dominant inheritance pattern. And as malignant or metastatic, I will go and change this later. As she mentioned, 30%, but if you go through the literature, they mention anything from 2 to 50%. And as mentioned before, the SDH mutations, and then very important with when these patients present, the sporadic ones, usually in the 5th decade, the patients with SDH mutations, new mutations, often in the 4th decade, and then the familial ones in the 2nd to 4th decade. It's quite interesting how things come up. This afternoon, just before this talk, I saw a family. Father who had carotid body tumors, and he brought his 2 children. The one is 18, the other one 20. The one has got bilateral tumors. The boy and the girl has got a unilateral tumor. And I actually wished that I could have seen them last week. Then I could have used them for this presentation. Professor Boy mentioned the paragangliomas, the chemoreceptors, neuroectodermal derived chromaffin cells, and in the carotid body specifically, these neuroblasts migrate along the glossopharyngeal nerve to where we find them. 90% will be adrenal, and 10% will be extraadrenal. And of the extraadrenal sites, 3% will be in the head and neck, of which 2/3 will be carotid bodies. Now, just looking at the carotid body specifically, it's a 3 to 5 millimeter structure at posterior and medial part of the carotid bifurcation. The vascular supplies to Meyer's ligament and the ascending pharyngeal. And then the herring nerve is from the glossopharyngeal nerve, as like I explained just before, as it migrates down to the bifurcation. The function is a chemoreceptor, and the effect is that it will increase respiration. Not to be confused with the carotid sinus, which is in the proximal internal carotid artery, which is a baroreceptor, and that also gives most of its visceral sensory efferent nerve to the vagus, and then also to the glossopharyngeal. When you look at the pathophysiology, Professor Boyer has mentioned some of this, but basically a chronic hypoxia theory, where this may be the patients who will present with it sporadically, where patients live at high altitude, or patients with chronic cyanotic lung disease, which will lead to hyperplasia and neoplasia. And this, I'm not going to spend too much time on, but as you are now well aware, SDH mutations, very important in the Krebs cycle, which will then lead to VEGF, vascular endothelial growth factor, which will lead to hyperplasia, angiogenesis, and neoplasia. When we look at the classification of carotid body paragangliomas, we can classify them differently. Firstly, with regards to etiology, whether they're sporadic, hyperplastic, or familial. And then with regards to the location, unilateral, bilateral, whether they're active. And then from a surgical point of view, the anatomic or imaging assessment is probably for us as surgeons a little bit more important. And then the genetic tests and whether they are active. This is when we look at clinical presentation, this is a meta-analysis that was published by Ross Naylor from the Leicester Group a couple of years ago. It's one of the largest. And you can see that 86% of the patients will present with a asymptomatic lump in the neck, and then the rest will have some clinical signs with regards to either the cranial nerves, headache, which would be due to hypertension, dizziness, vertigo, and so forth. Bilaterally, they will be found in 10%. And this picture on the right, where the patient's got the lump in the carotid triangle, is from the article that was published by Jacobs in 1954. Radiology, very important. On the left here, you'll see the operative pictures a little bit later. This was pre-operatively. You can see the two blood vessels, the internal carotid artery on the left and the external carotid artery on the right, with almost a circumferential covering of the vessels by the carotid body paraganglionoma. This, as you can see in this, it gives you a very good indication of what you would expect when you go and attempt to remove this tumor. It almost gives you a roadmap of what to follow. On the right is a CTA of the same patient which shows the Shamlin 3 carotid body tumor. Again, this Shamlin classification, very useful, predicting how much you're going to sweat when you have to remove this tumor. And important, the arteries and the nerves, the internal and external carotid artery, the superior laryngeal nerve, the hypoglossal nerve, and the vagus nerve. And those three nerves and two arteries are what we use to determine what we will expect and what we will find during surgery. As I indicated a little bit earlier, and we will allude to it later on again, that the complication rate of this operation, 10% cranial nerve injuries, obviously more common with the group on the right due to the encasement of the nerves in the tumor. Special investigations, patients living at high altitudes, a full blood count to look for polycythemia. If you suspect that it may be functional, or in patients where they may have familial paraganglionomas, I will do them VMA and metapherenins routinely. And as mentioned before, for patients where they have bilateral tumors, or if the patient or a history of paraganglionomas. In the past, we used to do MIBG scans in nuclear medicine, but now CT PET, data PET has replaced that. And then consider genetic testing after listening to Professor Boy's talk. I think that is a must. For obvious reasons, no biopsy should be done, and it's usually diagnosed on the clinical signs and the radiology that we perform. The management options, you can either treat it conservatively with radiotherapy, and then resection and reconstruction either with or without embolization. So what would be the rationale to wait and scan these patients? In the literature, two publications where they followed patients up for quite a long period of time. And in the one group, Janssen et al. Found that the doubling time was only 7 years with average growth rate of 0.8 millimeters per year. Langer found almost the same, and the issue is the risk of cranial nerve injuries, where if these patients have such a high risk of cranial nerve injuries, shouldn't you just then follow them up and before going and operating on them? However, they noted that surgery would be indicated if the patient had lymph nodes or there was pain or growth and so forth. Now, it puts us as surgeons in a difficult position because, often when I have to fly to a destination, I'm often faced with, especially here in Pretoria, with clouds and so on. And sometimes you get an opportunity to depart, and then you think, maybe I should just wait a little bit longer. The weather may clear, and then actually the weather gets worse, and that is unfortunately by waiting, you actually might place yourself in yourself and the patient in a much more difficult situation. When we look at radiotherapy, it's intensely modulated radiotherapy. In the literature, they differ with the amount of dose that they give and the fractions, but generally it's between 44 to 50. Suarez et al. Had the largest review with regards to radiotherapy, where they treated 127 patients. And they basically did like a meta-analysis, and they found that 25% of patients had a bit of a decrease, and 4% had progression, and obviously the patients had less cranial nerve injury. So they said that radiotherapy would only be indicated if you waited and it started to grow, that you may use it. And then specifically for patients with high anesthetic risk, or if surgery is not considered. I think for probably as the head and neck surgeons on the forum will agree that it is usually much easier to go and resect a tumor, whether it's a carotid body tumor or a squamous cell carcinoma, if the patient had not had radiotherapy, and it often makes the surgery much more difficult, and it's more difficult to find planes. Something that or a place where you can consider it is where the patients have this baroreflex failure syndrome, where they may have bilateral hearing nerve injuries. So sometimes if you've done a carotid body tumor, it's more applicable to patients with bilateral disease. If a patient had a carotid body tumor resected on the one side, and he has evidence of vagus or glossopharyngeal nerve injuries, that you may consider to do radiation for the contralateral side. I'm quickly going to say something about embolization. The rationale for doing embolization is basically that it reduces intraoperative bleeding and operative time, and then cranial nerve injury, and you have to balance that with the stroke rates that these patients will have. These interventions are not without their risks. You can do, there's basically two ways of doing it. You can either do transarterial angiography with embolization, or you can do direct puncture with onyx, which is what I do, and it was the way that I was taught. When doing transarterial angiography and embolization, usually you will target the ascending pharyngeal artery. When we look at the literature, there's conflicting views with regards to embolization. In the last 5 to 6 years, there's been 2 meta-analyses looking at this specifically. Robertson et al. Showed no difference between whether you embolize the patients preoperatively or postoperatively, and they looked specifically at bleeding, operative time, cranial nerve injuries, and a stroke. The second group said that there was a much reduced blood loss and operative time. However, there was no difference in cranial nerve injury, strokes, and length of stay in the hospital. And I think when you look at these meta-analysis, unfortunately, they group all the patients together. So they may go and do embolizations for patients with Shamlin 2 carotid body tumors, where that would usually not be indicated. It's usually the larger tumors where you would get a bigger benefit. And I put it to you that I think it's better just to use a tailored approach where you would select the patients where you think it would be necessary. In my practice, I use Onyx 34 intraoperatively, which I will also show a little bit later. In this case, it's a patient with a patient that was referred to me by one of our head and neck surgeons, Dr. Harry Moolman. This is an 18-year-old man or boy who had a jugular paraganglionoma, and quite a large tumor, as you can see on the left, and you can see the blush there, and then you can see the internal carotid artery and the carotid siphon, and then just slow flow into the brain. And on the right, you will see when I entered into the carotid siphon, you can actually see retrograde flow from the internal carotid artery, from the cerebral part of the internal carotid artery, almost like pulling all this blood from everywhere. And that is typically what we find. It just picks up blood from everywhere. On the left-hand side, you will see I did a angiogram through the right carotid artery, and then you can see flow all the way, cross flow to the contralateral side via the anterior communicating artery, and then you can see the anterior and middle cerebral arteries on both sides. Because this tumor stretched up all the way to the skull base, we coiled the internal carotid artery in the carotid siphon because the concern was that we would not, or Dr. Melman would not be able to get control at the skull base where the internal carotid artery entered. And on this side, you will now see the angiogram where you can see the blush, but no flow into the internal carotid artery. Patient had his resection, and he visited our hospital last week after quite a long stay in the ICU. Looking at the surgical management, I'm going to focus on patient factors, tumor factors, then surgical factors, and the anesthetic factors. When we look at the patient factors, it's important to take note of the age and life expectancy of the patients. Cardiac risk factors, and then BMI, neck mobility. The older patients often, I've had one or two where the patients had neck fusions, makes the procedure exponentially more difficult if you cannot extend and rotate the necks to the contralateral side. Obviously, as mentioned before, if there are some patient factors that would place the patient to higher risk, then you could consider radiotherapy and wait and scan, and then later radiotherapy. The tumor factors, whether they're metastatic, sorry, Professor Boy, metastatic or not, whether they are active, bilateral, then we would consider, are they resectable, and what would be the chances that you need to do a reconstruction in this patient. You have to plan these things beforehand. Usually the Shamlin classification will give you an idea of how challenging this procedure will be. And then if there's any cranial nerve involvement, I will routinely ask one of my ENT colleagues to evaluate the patients specifically with regards to their vocal cords, their hypoglossal nerve and so forth, to get an idea, glossopharyngeal, to get an idea of how severe this tumor is and what I may expect. When you look at surgical management, surgical factors, I think experience is very, very important. On the left, there's a picture of Professor Koormans van Marle. I was fortunate that he was one of my and Dr. Dirk Leroux here mentors. And when I started to do my first couple of carotid body tumors, I would refer the patients to him, and then we would do them together. Unfortunately, he passed away, as most of you know, 3 years ago, just this month. And he is dearly missed by most of us. And yeah, I'd like to honor him for that, because with his mentorship, I was able to start doing these procedures on my own. And for the young surgeons at the webinar, that is one of the things, well, probably one of the most important things that I would recommend if you have these patients, that you would go to people who've got the experience so that they can teach you and then you can teach the next generation. If the patient's got a very high bifurcation, I think and you need to do a transparotid exposure. It's not something that we as vascular surgeons commonly do, especially I think it is very good, and I would recommend to get in a head and neck surgeon or ENT who often do these types of surgeries to help you, specifically to protect the facial nerve. If you are an ENT surgeon, I would recommend that you get a vascular surgeon to give you a hand. And then don't forget to prepare the groin if you're going to need to harvest the greater saphenous vein, and make sure that you've got your shunts available intraoperatively if you need to do a shunt while you do the resection of the tumor. The regards to anesthetic factors, I mentioned there, the patients with tumors that are secreting adrenergic substances, that those patients are usually on alpha blockers, and so they should be well blocked, and make sure that there's a cell saver. And then we routinely use INVOS for regional oxygen saturation. Preoperatively, when you're going to discuss your procedure with a patient, I think in the literature now, the mortality has decreased to 2.5% and stroke rate to 3.5%. Thinking back of the Pantanovich group's publication in 1987, they had a mortality of 4.5%, and a stroke rate was more or less the same, and then the cranial nerve injury in their group was 10%. However, remember that for the Shamlin trees, you can expect in the meta-analysis by Ross Naylor, there was a 70% cranial nerve injury. And like I said, there's a direct correlation. Must-have tools in theatre is a bipolar, a ligature, a vascular set, and the cell saver again. This is the carotid body that I showed on the sonography a little bit earlier, and the CTA patient at operation a couple of weeks ago. I'm quickly going to go through the steps, and then I'll show a video of how this procedure is performed. I routinely do sonography pre-operatively before I do my surgery. I think it helps the surgeon to kind of plan ahead and to know what to expect. If you often see large vessels coming from the side, it kind of helps you to place your incision on the neck, how high you need to go, especially the patients maybe with lower bifurcations. Usually when you see that, you're quite glad. Then we'll usually start with the incision and anterior body of the sternocleidomastoid, split the platysma muscle, identify the greater auricular nerve superiorly. After this, we would extend, the external jugular vein would be divided, and the internal jugular vein would be mobilized laterally by dividing the facial vein. I find it very helpful to divide the digastric and omohyoid muscles, as it gives you a little bit more space to work. This is not necessary, but as with most things, I remember as a young fellow, when I was struggling with an operation, the first thing that the professor did when he came to help us with the procedure was that he would increase the size of the wound. So I think that is why I basically almost always create extra space for myself, and it's better to do this in the beginning of the procedure than during the procedure when the tumor starts to bleed. Very important is to identify the vagus and glossopharyngeal nerves. We try to identify them on the periphery. If you look at on the picture here specifically, you will see that this is the vagus nerve over here, and you can see these large blood vessels running across the tract of the glossopharyngeal nerve. And then right here at the top, you can kind of start to see the hypoglossal nerve in the periphery. And that would be my suggestion, is to identify these nerves in the periphery and then work towards the tumor. After this, we would identify the common carotid artery. In this patient, as you can see, it's difficult to see the internal carotid artery or the external carotid artery. The plan usually during the procedure is to start on the periphery and then work centrally towards the carotid bifurcation, where most of the blood supply to the tumor will arise. However, as mentioned before, a lot of the blood circulation, or actually the tumor blood supply, comes from the nerves or the surrounding tissue. And while doing the procedure, then often I will decide whether I want to do embolization or not. depending on how vascular the tumor is. Often when you get to the bifurcation, most of the tumor's blood supply has been ligated, and as a lot of the surgeons it will shrink, and then it's not, you don't have to do embolization. I find usually the superior part a little bit more challenging, and in those cases where there's a lot of blood supply coming from the superior part of the tumor, I found that embolization is quite helpful. We can discuss the clamping of the carotid arteries and giving heparin on the table. I know to a lot of the head and neck surgeons it sounds like madness, but I have had patients where we've used onyx in the tumor, where I could actually see on the angiography that some of the onyx had gone into the carotid bifurcation. I had to then open it and remove it. Fortunately, the patient did not have a stroke. And after that incident, I started to clamp my carotid arteries after giving heparin. Also, I think it also decreases your stroke rate, although I don't have any evidence for it. For when you basically handling and pulling on the internal carotid artery for quite prolonged periods of time. After you've done all of that and you've dissected out the bifurcation, then usually you will lift the carotid artery and the internal and external from the tumor, and then you will start to, or I would do the posterior part of the tumor. There's different surgeons have different ways of doing this. Some will start at the bottom and work their way up. Some will start at the top and work their way down. I found that for me, it's easiest just to start in the periphery and work to the center. Just remember, when you are dealing with a posterior part, to look out for the superior laryngeal nerve. Here is the same patient after the tumor has been removed. You can see the vagus there. You can see the hypoglossal nerve over there. The digastric was divided, and right in the middle, right at the back, there you can see the superior laryngeal nerve. As I mentioned before, try to always stay in the subadventitial plane. That makes it much easier. Use a bipolar and ligature to maintain a dry surgical field. The nerves as guides as to where you should go. And then very important, especially in the older patients, when you do these operations, make sure that patients don't have complicated carotid plaques or calcifications. And because that can also contribute to a higher incidence of stroke. And then with regards to embolization, this patient, I didn't do any embolization. We just removed the tumor. I'll quickly play a short video on how we perform the procedure and just talk you through it. Incision on the anterior part of the sternocleidomastoid. This is the digastric muscle. Just be careful at the mastoid that I generally don't go too close to avoid injuring the facial nerve. This patient quite a bulky digastric muscle, but you do create a lot of space for yourself at the superior border. After this, identifying the hypoglossal nerve and then slinging it and then using that and following it up proximally so that you can get to the root. Sometimes you can see that you will find the descending hypoglossal vein, nerve, as you can see over here. You can also follow that up to get to the main trunk or the stem of the hypoglossal nerve. You can see here we've dissected the nerve off the tumor. After this, I would then often go and identify the vagus nerve and just mobilize the jugular vein laterally. What I'm doing here is I could see the external carotid, and this is a good example of what not to do. As you can see, I could see the artery there, and I wanted to see if I can get through. However, after a while, I found my wits and got back to doing the procedure the proper way, isolating the common carotid, following up the common carotid, the external carotid exposed here. You've got the vagus at the top, you've got the bifurcation over here. And then after that, we started operating and working on the internal carotid artery. Try to stay in the subadventitial space with bipolar and sharp dissection. And then often what you will find is when you work on, especially on the young patients, they may get some vasospasm. You may, like I said earlier, make sure there's no plaque. And then maybe sometimes you just rub it a bit and they do get a little bit of vasodilatation. After slinging the top part, we would then have that. So we've isolated the vessels. You can see on the top right, we've clamped the internal external carotid artery. There we're doing the angiogram. You can see the tumor over there. This was quite a vascular tumor with a lot of blood supply from posterior. After injecting the onyx, it makes the surgery much easier. You still have bleeding, but you have a lot less bleeding. This is dissecting the bifurcation out, looking for the ascending pharyngeal. And in this picture, you can see, or this part of the video, you can see we've dissected the whole internal carotid, common carotid and bifurcation away from the tumor. And you basically only have the tumor posteriorly. Then usually with a ligature, it makes it a little bit more easier. This is just the vagus. Remember, at the superior part of the tumor, where the internal carotid artery, you must just watch out for that vagus nerve at the top. And then often with ligature staying close to the tumor, we would then continue to remove the tumor with the ligature. If you stay close to the tumor, the risk of injuring the superior laryngeal nerve is much less. At the top there, you can see the internal, the hypoglossal nerve. Posteriorly is the vagus. Behind that, we always with the blue slings around. And then we're just getting the last bit of attachment at the superior part. And there you can see the carotid body tumor removed and finished. You can actually see the indentation of the, over there, you can see how it was sitting in the carotid bifurcation. Just hemostasis. And then just closing quickly. And yeah, so this is the quickest carotid body that I've done. I think it took me 5 minutes. Now, surgical complications we have to mention. As I mentioned before, the most common is the hypoglossal nerve, vagus 8.7%. The size more than 4 centimeters is indicative of a high risk. And there was a group that looked at the distance from the base of skull, that what they basically said is for each centimeter that you are closer to the skull base, because they used that as the reference, there was an increase of 150% to injuries to these nerves. So, and that is usually the area that's the most difficult part to dissect, is that superior part underneath the digastric muscle. Stroke rates 1 to 3%, and the mortality, like I said earlier, has come down from 0.4 to 2%, more or less. So I think if you and your patient wants to arrive safely at your destination, which is a safe operation where the patient has as little complications as possible, I think it's very important to do pre-op planning, like with any flight you would do. You look at the weather, you look at maps and so forth, and plan the way that you're going to fly. And the same applies. And I think that's the main role of radiology. When you look at the radiology, it's not just for diagnostic purposes, but it's to help you to visualize the way that you're going to do this procedure. Preparation is very important. Make sure you've got the correct tools. When you perform the procedure, I was fortunate to be taught by my teacher when I started to fly. Was an old instructor. He was like 70 years old, a real grey beard, and he would teach me a lot of things that I think only comes with quite a couple of years, and he's made all the mistakes. So if you're going to, for the younger surgeons, start to embark on doing more of these types of procedures, go to the greybeards and get them to help you so that you will also be able to teach the next generation. Very important, like in aviation, it's important to know your landmarks so that you have your spatial orientation correct during the procedure. Know where your vagus nerve is, know where your hypoglossal nerve is, know where your bifurcation is. Your glossopharyngeal, if you're going to go glossopharyngeal nerve, if you're going to go a little bit higher. You have to have that spatial orientation correct. Target the bifurcation, and then, like I said earlier, consider embolization. And then, as Professor Boy said earlier, if you do these procedures, we send most of our histology to Professor Boy. So, fortunately, and we've identified 2 of my patients have the SDH mutations, which is in a follow-up program. Thank you very much.
Thank you very much, Dr. Gerloff. Really appreciate it. And I think this is once again an extremely difficult topic to try to do in a limited time, and this was very well done. I mean, well done on that video that you showcased. I mean, it's always difficult to capture surgical, specifically anatomical structures rather appropriately, and we could visualize that really nicely. Just quickly, the poll that we did just a while ago, interesting. So the most common imaging modality used in your unit. I mean, it was quite head-to-head ultrasound and CT. So I mean, it seems that a lot of the audience actually use CT as the first modality. Talking about that, I think we're now at the Q&A session. We thought of ending off the webinar with a case study, also with some polls there. So maybe we can open the case study, and I want to ask all the panelists if you'll be so kind to just put your videos on, and that we can have some interactive discussion as we enter to the last part of the webinar. So maybe just one question while we start with the case study. Prof. Boy, just out of curiosity, do you know the costs in South Africa doing these studies? I mean, you obviously elaborated to it on your in your lecture, but I mean, cost-wise, what are we talking about in rand, if I may ask?
Yes, Dr. Kluge. So if you want to do this genetics, then basically the blood is sent to Germany by the geneticist, and then they do a cento hereditary cancer panel, which basically then also has these SDH genes in it, and it costs around 10,000 rand. At the end of last year, it was around 7,000 rand, and now currently it's 9,800 rand. So unfortunately, due to the weakening of the rand, that's a problem.
Thank you very much. We put some more poll questions up. I mean, we decided to put all 3 on at the same time, and then everyone is welcome to answer on your own time. But let's start with the case study. So we have a 42-year-old male, hypertensive, macrocytosis, had previous left-sided tumor surgery, and to elaborate, previous left-sided carotid body tumor surgery. He's got a background, family history of the mother and the daughter that has been diagnosed with lupus. Vital signs: hypertensive, as you can see, slightly overweight. If we continue to the next slide, clinical summary from examination point of view: sinus rhythm on ECG, septal ST changes, possible HOCM that needs to be excluded due to long-standing hypertension. I mean, from a cardiology point of view, mitral valve regurgitation and parasternal systolic murmur. So clinical examination specific to the radiologists: palpable pulsating mass, level 2, left-sided. and the rest of the head and neck examination with the normal limits. So this patient was worked up, and as mentioned throughout the whole webinar tonight, I mean, it was worked up for a secretory tumor. That was the case. Was the case. But let's have a look at the imaging. So we're having a young patient with previous surgery of a carotid body tumor that's secretory. Dr. van Papendorf, will you mind commenting on the imaging, if you don't mind?
Yes, sure, anytime. So what we're looking at is axial slices of a CT angiogram. So we'll focus on the zoomed in image. On the right, you can see this well-circumscribed mass lesion. It's homogeneous and it's avidly enhancing, and it's also splaying this internal and external carotid arteries. Like we've mentioned, classically will be found in carotid body tumors. Next slide, please. So you can see that there's a similar appearing mass also evident on the left, maybe with a little bit of less tumor invading or displacing between the vessels on the left, but I think this was the site of the recurrence, so it might be a little bit atypical recurring in this location, slightly micronodulated contour, but also with similar characteristics. Next slide. So this is just a sequence in a different plane. You can see that these are maximum intensity projection images, so the slices are a little bit thicker. And basically what all three images shows us, and it's been demarcated here with the arrows, is basically the bilateral carotid body mass lesions, these avidly enhancing homogeneous hypervascular lesions. And next slide. And this, again, just depicts it in the sagittal plane. So I think this is the one on the left. It's slightly smaller, but still in relation to the carotid body. And the one on the right having this more classical lyre splaying type of appearance, as we mentioned earlier. Next slide. And then you can see them juxtaposed, or just basically on the same slide. You can see both of these lesions. And on the right, just to note that there is no pathological lymphadenopathy in the vicinity. Next one. I think that's all.
Yeah, I think that's all. I think that's all images that we have. So I'm going to open up to the panelists, vascular surgeons tonight. On the panelists, some comments. You've got a patient, relatively young, recurrence, bilateral disease, secretory tumor. Can I have some comments from the panel, please?
Yeah, maybe I'll start. So this is what would appear to be clinically somebody who's got some form, most likely, of a hereditary or some germline mutation, probably the SDH, like we've alluded to. The concerns from the fact that he's got a secretory tumor, and one needs to exclude your other form, or rather other paragangliomas, or even possibly a pheochromocytoma. So for that, I would offer this patient a PET-CT so that one assesses them holistically. So should one exclude a pheo or paraganglioma elsewhere, then I would proceed to address this medically, obviously with the alpha blockade, initially fluid resuscitation, and the typical works with the pheo. Then he's got bilateral disease, and my understanding is that the left-hand side is a recurrence. So I would want to probably work on the easier side, that being the right-hand side, because it's a virgin territory, and it looks more like a Chamberlain 2. And I think I'll probably address that one first. For the left-hand side, the recurrence, and I would think there is an option of conservative option of radiotherapy, but probably a bit more conservative, and follow that up and see, should there be progression of disease, then maybe I'll consider radiotherapy. But that's how I would go about with this case. Thank you.
Okay, so I think that's actually talking through the patient from the beginning to the end. Thank you for that, Dr. Ngema. Maybe just the patient didn't have any, at the time, no cranial nerve fallout after the initial surgery. Let's hear from Prof. Piazza. What is your opinion? Dr. Leroux, may I ask while Professor...
Sorry. I've activated my audio now. Well, my vision is honestly exactly the opposite, since the most trouble side in this patient is the left one, and therefore it was the recurrent one, and this patient has a high chance, I would say, to have a metastatic disease because he's young. It has some kind of inherited disease. He has a bilateral disease, secreting disease. So all these are bad factors and are at risk of malignant disease or metastatic disease. So I would the right side has got a shambling 1/2 disease, not troublesome on the internal carotid artery. So I've got at least 1-2 years in front of me to treat that disease. But the left side has already been treated and is still recurring. So perhaps that's the most dangerous part. I have to be prepared to face with the malignant disease, with a disease that needs some kind of resection and reconstruction of the carotid axis. So for sure I need a major vascular and second vascular plan to reconstruct this with the saphenous or whatever, and I would address this as the first thought of my plan.
Yeah, and that's a nice thing of discussing this. Dr. de Klerk, what is your opinion?
So, are you speaking to me? It's Dr. Leroux.
Oh, sorry, Dr. de Klerk. Oh, I'm so sorry. Dr. Leroux.
Yeah, and I also agree with Prof. Piazza. In this case, we've got a recurrent. I would like to go in and resect that tumor. I usually have in my toolbox a head and neck surgeon with me. Alan Kearns and I usually do these things together. In these recurrent cases, we do extensive nerve monitoring. So I have a neurophysiologist monitoring the nerves for me because you are going to run into trouble with all the scar tissue in that area. As a matter of fact, I've started in the last 2 or 3 years routinely used nerve monitoring, monitor the glossopharyngeal, which is at risk. In this case, I would suspect the vagus, the hypoglossal, and also the facial nerve. So, and like I say, as part of my toolbox, I've got a head and neck surgeon so that we can get way up into the base of the skull if we need further dissection. I didn't see any lymphatics involved or lymph nodes involved, but certainly if there are lymph nodes involved, we will take those lymph nodes as well with the head and neck surgeon. So I would definitely go for the difficult one first and then deal with the other one at a later stage. But then again, yeah, this is a recurrent and a bilateral. Chances are high that the other side is also a bit of an issue, and then get proper histology and proper confirmation as to the genetics of this tumor. Thanks.
I think you make a very good comment there about nerve monitoring. I mean, a lot of time we use it just from a defensive point of view. But I mean, nerve monitoring definitely plays a role. The one thing that I think that sometimes is underestimated is just the way that how you handle the nerve. I mean, it's always interesting for me if you do radical neck dissection for a squamous, for SCC, for example. I mean, you can mobilize that whole accessory nerve throughout the SCM. I mean, you dissect the whole accessory throughout the sternocleidomastoid muscle, and those patient doesn't have any fallout post-op. And then you work on it with, for example, with the carotid body and pull on the accessory nerve, or even a benign tumor, and those patients have post-op fallout, even if the nerve is fully intact. So I think nerve monitoring definitely, I fully agree, plays a big role. I think in this case, it will be for 2 reasons. Number one, obviously intraoperative. It will guide you. I mean, you obviously will use your same landmarks. I agree with, I fully agree with you on that. But also, I mean, it's unfortunate that we work and we operate in a time of litigation, that you have to protect yourself, especially in cases like this of high-risk surgery. So I agree with you. I think that's a good comment made by yourself. Dr. Elof, can I ask if you want to comment?
Thank you, Johan. Yeah, I am going to, unfortunately, this is my patient. So, yeah, the plan is to do a resection for him on the left. On sonography, actually, you can see that it looks like there is ingrowth into the common carotid and into the internal carotid artery. On the radiology, there you would see that there was no splaying of the bifurcation as you would normally find on the contralateral side. And that is almost like the tumor is growing. You actually appreciate it a little bit better on sonography, where the tumor is growing into the external and internal carotid artery. So the plan is to do a resection for him, probably with a reverse saphenous vein graft reconstruction. And I will probably ask one of my friend head and neck surgeons to assist me to get maybe a transparotid approach as well, to get nice and high and to clear that whole area. He's also being worked up by the physician who has started him on alpha blockers, and he would have, or he should have had his CT dotate PET scan, unfortunately yesterday, but we could not have it done before the webinar.
Maybe while we on that topic, Philip, thanks for that. Dr. van Poppendorf, I mean, that was actually one of the poll questions. Will you quickly just, I mean, there is some registrars around this webinar tonight as well. Will you quickly just distinguish, I mean, it's a basic question, but quickly distinguish between a PET CT FDG and then a PET DOTA. And maybe if you won't mind just looking at that poll and give your opinion about that poll question, please.
Yes, sure. Okay, so FDG PET scan is based on a fluorine, but I think the most important difference between the two is that FDG stands as short for fluorodeoxyglucose. So it is a glucose-based radiotracer. In other words, sugar. It's just plain sugar, and it has a much more broader spectrum for any type of hypermetabolic disease within the body. So any new plastic process that's hypermetabolic will take up FDG, or sugar-based, will consume sugar, and thus will take up FDG-based the radiotracer. Whereas dotatate is based on gallium 68, and it is specific for the neuroendocrine tumors like your paraganglioma and pheochromocytoma. So that would be the most basic difference. And having a look at the poll question, I see most got the answer correct. So we use dotatate scanning for familial cases or genetic inherited diseased cases. These cases mostly associated with multicentric disease, bilateral disease, and as we've mentioned also, if you have a secretory tumor, the head and neck paraganglioma are less likely to be secretory, so you have to do a PET dotatate scan that scans the whole body, head, neck, chest, abdomen, and pelvis, to look for other more often secretory paraganglioma along the sympathetic chain and the adrenal glands.
Thank you, Dr. van Poppendorf. Maybe let's just quickly end off the polls. Prof. Boy, that was actually your question that you sent in. You want to comment on question 1, the polls?
Yes, Dr. Kluge, I'm just looking here at the answers, and I think most got it right. The SDHB immunohistochemistry that we can do. The S100 stain is more commonly used to check for the supporting cells or the sustentacular cells that we find around those little zellballen. And sometimes when there's loss of that, then there's diffuse growth, which is a negative prognostic indicator. AE1, AE3 is a cytokeratin. That's just a normal epithelial marker, and these are non-epithelial tumors. So when it's positive, then you're not dealing with a paraganglioma, but well done overall.
Dr. Leroux, can I ask if you wouldn't mind commenting on that last question also? And it was actually poll question 3, who of the surgeons around the table actually use cyanoacrylate in carotid body tumor, and do you think there's a place for it? Where do you use it? What is your experience with it, if I may ask?
So yeah, I don't use cyanoacrylate. I've used onyx on occasion. I find that I think if you look at some of our literature, that cell saving probably saves you a unit or so. So I try not to use any embolization of cyanoacrylate. Have used onyx before, but in general, I just go and do a full resection with cell saving if necessary.
Thank you very much, Prof. Piazza. Your opinion about that?
Well, I have never used the onyx, but I frequently use intraarterial embolization, especially for problematic Chamblin-2 and all Chamblin-3 tumors. And for problematic Chamblin-2, I mean not only large Chamblin-2, but those that approaches the skull base. Because Chamblin is just a part of the problem. The cranial extent of the tumor can change a lot your vision of this tumor. And when I see a high tumor, even if it's a relatively small one, I prefer to have a good embolization on my side. And I do it by transarterial embolization, never by onyx.
Thanks, Prof. Prof. Joseph, any comments from your side? Anything you want to comment? Any questions?
Not really. I don't see anything on the chat either. I wanted to maybe ask about that case that you just presented. I would agree that I would do the easy side first on a bilateral carotid body, to be honest. You just don't want to hit complications on the bad side and then still be left with an easy side. And doing recurrence in carotid bodies is really not pleasant. But I wanted to ask, nobody's chatted about radiation therapy, particularly in that last case where you have a recurrence on the one side. Would any of the panel consider that on the recurrent side, particularly with carotid artery involvement? Just a question. I see. I don't know if there's a radiotherapist on the panel or not on the panel, but in the meeting at all. But I'd like to hear what people think about that.
If I can make a comment, I would have thought about that in a 65 or 70 years old guy, but never in a 42. Because whenever you treat by radiation a tumor like this, you will have problems in the next 20 years. Whatever the outcome of the radiation, you will have secondary cancer or radiation-induced cancer or whatever, and perhaps the progression into the carotid artery will happen anyway. So this is something that you can consider, but in the last part of the life, not in a 42-year-old guy. That's my opinion.
Yeah, so I've been involved in 2 of these cases, also 2 both young aggressive tumors. One was a young girl from 18 years, had a resection at the age of 15. As a matter of fact, I remember the case very well. I did it with Martin Villa and Jay Pillay a couple of years ago. She had radiation and still had growth of tumor, and that was a nightmare. And she unfortunately passed away a couple of years later because she just couldn't get anything done because of the radiation damage to the neck. So in a young person, I would really try and steer away from radiation. The second case was also a 30-year-old, also had radiation, and then still had recurrence. I think I'm not sure what the radiation protocols are nowadays, but in essence, these tumors seem to be quite resistant to the radiation. If they then grow, then you're in trouble. So I think full surgical resection and a neck dissection is the way to go, especially in a younger person. I agree with Prof. Piazza, and in the elderly, there might be a role for that, but certainly not in these younger cases. Thank you.
Dr. Leroux, maybe that's a good comment that you made about the radiation. I think maybe something that I think to see that's working, for especially in a post-radiated neck, that if you sometimes go low down in the neck as part of a neck dissection, and when you transect your sternocleidomastoid, obviously at your clavicle caudally, I mean, you usually get a good plane there. And if you get in the right plane there, usually you actually tend to get structures easier. Now, obviously, your problem comes at the carotid body, and that's where the vascular surgeons are of help. But I mean, usually when you get in the right plane far away from your pathology, you tend to stay in that plane and then go up more cranially. And that helps a lot, because usually a lot of times then you're in the right plane in terms of all your structures that's of importance, and you actually land up in the right planes. Identifying obviously the structures as you continue more from caudally to cranially. Dr. Elof, any comments from you?
Yeah, I agree with Dr. Leroux and Professor Piazza that I think, and for me in this case, that was the issue, is this patient is an engineer, he's fit, he's quite active. There's obviously, it's a patient with high risk, but I think like I said earlier with aviation, sometimes you have to pick a time to go and to depart on this procedure, and that is why I decided to do a resection. He's still busy with his workup, and he's got an active tumor, and we're busy excluding other paragangliomas at the same time, which may change the management of this patient. But I think that would just a resection would probably give him the best chance at this stage. And I also don't want to go back into a radiated neck and making a difficult procedure exponentially more difficult. And that's why I decided to probably offer him a resection on the left side, and then on the right side, as I mentioned before, the growth of these tumors and the doubling time is quite slow. So we have another year or two to manage the contralateral side.
I think there's one question I see from Dr. Sarwala Ramagoga. Dr. Ramagoga, can I maybe post this to the panelists? Dr. Ramagoga asks, do you ever consider balloon occlusion test pre-operatively, especially in a Chamblin 3? Can I quickly ask the panelists as we are busy closing off this webinar?
I'll take that one. I think the balloon occlusion test is a 50-50. So you might not get any symptoms during the balloon occlusion test, but you can still get a stroke. As far as I'm concerned, so no, I never do that.
Same here. No, thank you.
Well, I can consider it in a very high and very troublesome Chamblin 3 lesions. And I agree that it's not 100% proof of anything, but if it's positive, I mean, if the patient has got an ischemic change after one side occlusion, then can be a very high reason to put the problem of wait and see or whatever in a different perspective. Obviously, if it's negative, the patient will have again the possibility to get a stroke in case of no reconstruction, but in case of positive test, he will be able to deny the procedure because it's too risky. And it's again in a medical legal perspective is something that I strongly suggest to do for very difficult cases, very troublesome cases.
As that case that I showed during my talk a little bit earlier, the patient of Dr. Moorman, where the tumor extended up to the base skull of the base of the skull, and where we were concerned about getting control distally. In that patient, we did him awake, and we did do a balloon occlusion test because I wanted to coil the internal carotid artery in the carotid siphon, and only after I had done the angiography on the contralateral side, seeing good contralateral flow, and doing the angiography in the carotid siphon where you could see retrograde flow towards the tumor, that with the balloon occlusion test was after I did that, and I occluded it for a couple of minutes and he didn't have any symptoms, I decided to place the coil, because after you've placed that coil, there's no turning back. So yeah, that. So I don't do it routinely, but I think sometimes, like in this case that I showed, you can sometimes it kind of gives you a little bit, makes you feel better.
Dr. Khelov, we should work together. We have 100% agreement in every aspect.
So I wanna thank each and all of you. I really think this was very informative, and thanks for all the great lectures. I think I'm allowed to say it was really lectures of top notch. Thanks for all the presenters. Thanks for the panelists being so kind to give up their time tonight and the comment. I know you all are busy. Surgeons are busy guys. I don't know if anyone wants to make a last comment. My co-host, Professor Joseph, I don't know if you want to comment, the last comment before we end it off. Just for everyone that's still around, this is and was CPD accredited, so your CPD certificate will be sent through by email within the next 24 to 48 hours. Prof. Joseph, I don't know if you want to end off the webinar, but or any other comments from anyone else before we say goodbye.
Well, I just want to thank everybody, Johan. It was really good, very interesting. I mean, these are really tricky and challenging sometimes. So very good topic and great choice of lecturers. Thank you very much, and thanks for everybody.
Thanks, Prof. Joseph. Anyone else? Thank you very much. Enjoy your night. If you have to travel home, travel safe, and have a good night's rest. Prof. Piazza, thank you very much. It's highly appreciated. And thanks to all the attendees. Take care of yourself. See you again with the next follow-up webinar soon. Take care. Bye-bye.
Bye-bye.